Kamal, the floor is yours.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Alhamdulillah, salatu wa salam ala ashraf al-anbiya wal mursalin. I would like to thank Dr. Aida and the organizing committee for inviting me for this interesting conference. I will start without delay about when I was asked to talk about emergency in pediatric cardiology. I thought it will be more useful if I talk about case scenario more than one or two. Because if I speak about one case in detail, it will be less useful than taking snap for 2 or 3. Although pediatric emergency is not common, but also it's not uncommon. So if you are working in general pediatric, in ICU or PICU, definitely you will encounter 1 or 2 of those cases during your life. I have no disclosure. So remember, cardiac emergency can mimic sepsis, severe pneumonia, asthma, metabolic crisis. So you have to be aware about the cardiac and put it in your mind when you're facing a critical patient. So first case, we have 7 days old male infant, previously well, presented with poor feeding, lethargy, respiratory distress, and found to be failed, tachypneic, tachycardic, weak, absent femoral pulses. Blood pressure present in the arm, absent in the leg, severe metabolic acidosis, oliguria. So from this scenario, all people will suggest maybe left-sided ductal dependent lesion, either QARC, interrupted aortic arc, or hypoplastic left heart syndrome. But also you have to search for other. As I mentioned, metabolic screening for metabolic crisis because he's 7 days and just starting feeding. Also sepsis, you have to put it in mind. So if we are speaking about left-sided ductal dependent lesion presented as emergency in the day 7 of life, you have to put in your mind could be critical aortic stenosis or severe coarctation or interrupted aortic arch or hypoplastic left heart syndrome. So the clue here, we have collapsing neonate with shock, differential cyanosis, because the lower body will be supplied by the ductus arteriosus, so from right to left. So if you measure the saturation, it will be normal in the right arm, it will be low in the leg, and blood pressure will be non-recordable in the lower limb if it's very critical. In the presence also of oliguria, anuria, severe metabolic acidosis. So what you will do? Urgent echo twice to judge about what is the diagnosis, and prostaglandin, don't forget, it's life-saving. You can start it even in the emergency room. If you don't have echo, and this is the picture clinically, go ahead and start prostaglandin, there's no harm. I don't know any condition in the cardiac will be harmed from prostaglandin except one condition, which is total animal pulmonary vein drainage with obstruction. And this is not the usual presentation. So start the prostaglandin, of course, mechanical ventilation and correct acidosis. So what is the definite treatment? After you stabilize the patient, start prostaglandin, refer him to cardiac center, or if you are lucky in the Musa, you can proceed with the surgery. So if it's aortic stenosis, usually they will go with balloon dilatation, dilate the aortic valve, and if it is a coarctation, they will go for usually surgical repair if the patient is less than 6 months. Just a few words about interrupted aortic arch. When we say it's interrupted aortic arch, there is complete separation between the ascending and descending aorta. And it's a 3 types. Either the interruption is distal to the left subclavian artery, that means all the neck vessel before the interruption, or type B, where the interruption is between the left subclavian and the left carotid. Here the left arm will be low saturation. So always check the right arm saturation. Or type C, where the interruption between the brachiocephalic and the right carotid. This is the 3 types. The commonest is type B. So the treatment for interruption, again, immediate treatment, start prostaglandin to keep the ductus open. And the different treatment, referral for surgery, and they will do anastomosis between distal and proximal arch. In hypoplastic heart syndrome, it's a bit more complicated, but the initial management will be the same. And now most of the center, they are shy to operate in hypoplastic left heart syndrome. I don't know, Dr. Matar here. I don't know about Musa. Are you operating Yeah, actually in the past 3 or 4 years, all my patient hypoblast, they put him no code, support, comfort care. Because most of the center, because the poor outcome in the future from Glen and Fontaine. Anyway, in hypoplastic left heart syndrome, it's more severe. So not only the coarctation or critical aortic stenosis, there is hypoplastic left heart. So that only this is the cavity of the left ventricle. So you have to do palliation, 3-stage palliation. And this is how it's appear in echo. See the left ventricle, this is the normal. See the left, this is the left atrium, left ventricle, right atrium, and right ventricle. And see in the hypoblast, it's chunk of muscle only. And this is only the cavity of the LV. So immediate management, the same. Start prostaglandin, keep the ductus open to save the life of the patient. If you are planning to do surgery, if you are not planning, please don't start prostaglandin and compassion care, and just talk with the parent. Especially if the parent they have 4 or 5 or 6 kids, because this is, if you proceed with this palliation, that means you are keeping the parent in the hospital. So, just a brief about hypoplastic surgery. It is a 3-stage. The first stage is called Norwood surgery. What does it mean? Simply, Norwood means we are utilizing the pulmonary artery to pump the blood to the body. And we disconnect the pulmonary artery from the lung. Because now I have one pump failure, which is the LV. So I will use the RV as the systemic ventricle. And I will direct the deoxygenated blood coming to the right atrium directly to the lung without pump. It will be done in the stage. Stage 1 is Norwood. So where the blood will go to the lung from called BT shunt, blood closing shunt, or from Sanu shunt. In other center they do Sanu shunt. Next stage, when the patient is at the age of 6 months, now the shunt is not enough, so we have to do for him Glen. Glen is connecting the superior vena cava to the lung directly. And at the age of 2 years or 3 years, if the pulmonary vascular resistance is suitable, we will proceed with the Fontaine. Fontaine connecting the inferior vena cava to the pulmonary directly. By completing Fontaine, what will happen? The heart will pump like the LV only. And all the pulmonary blood flow coming without pump. So it will face a lot of problem. Especially now the main pump is the RV. And God created RV to pump only to the lung. Now we are forcing RV to pump to the whole body. So definitely with time it will be weak and it will fail. And what else? The pulmonary blood flow coming without pump. So if you have increasing resistance, patient will present with ascites, superior vena cava syndrome, and name it. That's why most centers now they are stopping doing this type of surgery for hypoblast, and they will go with conventional care. So key point: left ductal dependent lesion, where the life is dependent on the patency of the ductus arteriosus because of the left side lesion. Often present at the age of 7 days. Always considered in shock neonate with absent femoral pulses, so prostaglandin is life-saving. Second scenario, now we'll go further. It's not a neonate, a bit older, 2-month-old male infant, sudden profound cyanosis during crying. Usually come in the early morning to the ER, born normal vaginal delivery, discharged with the mother in good condition, and the mother told you, well, I went to primary health center and they told me there is heart murmur in the past. But nothing was done. So likely with this patient, keep in mind if the patient coming early morning, crying with severe desaturating, saturation can reach down to 40s. Think about tetralogy of Fallot. In tetralogy of Fallot, we have 4 things. We have VSD, right ventricular hypertrophy, and subpulmonary stenosis as well as pulmonary stenosis. It's the presentation we'll see in the next slide is varies according to the stenosis in the subpulmonary area. But in patients with TIT spell, usually present with sudden episode of severe cyanosis, precipitated by crying, sometimes by constipation, or feeding. So what will happen in tetralogy of Fallot? This is the tetralogy in steady state. We have obstruction, yes. We have right to left shunt, but not to the degree that patient will present with saturation of 40s. So in Tethysbal, what will happen? There will be sudden spasm in the infundibulum, so more right to left shunt, so the patient will develop severe cyanosis. So if the patient develops severe cyanosis, hypoxia, hypercapnia, metabolic acidosis, patient will try to hypercapnia, increase systemic venous return, increase right to left shunt. So we'll go into this vicious circle. If you don't interfere with the patient, patient may die. This is really a critical and really an emergency. So we have to cut the circuit. As I mentioned, tetralogy of fallot presentation, some patients, we call it pink tetralogy. Pink tetralogy, that means he's not cyanosis. He presents like the VSD and like heart failure. Why? Because the obstruction in the subpulmonary area is very minimal. Yes, there is overriding, there is a VSD, and there is stenosis, but the stenosis is very minimal. So patients will not present with stenosis, will present with heart failure picture. We call it pink tetralogy, but this is not the case in our patient. So deep cyanosis, tachypnea, irritability, inconsolable crying, diminished murmur during the spell. Why diminished murmur? Because there is spasms in the infundibulum. And we know the murmur in the tetralogy is not because of the VSD. The murmur in the tetralogy because of the obstruction in the subpulmonary area. So if you have spasm or near complete obstruction, you will not hear the murmur. So just this is the echo for tetralogy of fallot. We have overriding of the aorta, clear in this image. So this is the aorta and this is the ventricle septum. See the septum is coming to the almost 50% overriding we have here. And if you do angio to look for coronary, you will see the infundibulum stenosis and the degree of hypoblast of the pulmonary artery branches. So what is the treatment if you encounter a patient in emergency and you suspect tetralogy of fallot? Again, if you don't have facility to do echo quickly and the patient is typical presentation, start. Keep the patient calm, knee chest position. Even the patient is infanted, the mother carry the infant while bending the knee and the hip, flexing. This is to increase systemic vascular resistance. If you increase systemic vascular resistance, what happens? We are trying to reverse the shunt through the VSD. Instead, it will be pure right to left. We'll let some left to right shunt, so we'll cut the circuit. Administer oxygen, maybe, but it is a limited benefit. Give IV fluid to increase systemic vascular resistance. Sodium bicarbonate to correct acidosis, and provide sedation, morphine. They believe if you give sedation, the infundibulum spasm will be less. Use medication, beta blocker. Also beta blocker, they believe it decrease the heart rate, improve the ventricle filling, and improve the systemic vascular resistance and reverse the shunt. And you can get phenylephrine, which is a vasoconstriction, also to increase the systemic vascular resistance. Consider surgical intervention or consider ECMO if you have facility. What is the long term? Long term treatment is surgery. You have to correct the stenosis, remove the muscle which is obstructing the subpulmonary, put the transannular patch to enlarge the pulmonary artery and close the VSD. Till you are waiting for surgery and the patient has episode of Tethysbal, you can put on prophylaxis propranolol. So, cyanotic spill is life-threatening emergency. Recognize early signs: irritability, deep cyanosis, hypercapnia, immediate intervention, critical surgery is the definitive cure. We'll go to case number 3, and this is the last case. It's rhythm disturbances. So, 3-month-old male infant presented to emergency department with fever, diarrhea, vital sign, heart rate is 190, regular, respiratory rate 30, saturation 97, blood pressure 95/70, and temperature 38.5. So he has fever, moderate dehydration, and ECG done or rhythm strip. So this is the ECG. I hope it's clear. Who will start adenosine or esophageal maneuver? Good. Why? Well, yeah, because this is sinus rhythm. If you notice, there is clear B wave in lead 1, and lead AVF, and the B wave is positive. So this is originated from the sinus. If you combine this ECG finding with the history, fever, this is sinus tachycardia. So treat the underlying cause. So I have another patient, 5 years old girl, presented to emergency department with complaint of rapid heart rate, history of similar event in the past, but treated in another hospital, no records available. Feels well, and very important, this patient feels well. No fever, no pain, and also no anemia to trigger this tachycardia. So this is the vital sign. Heart rate 250, respiratory is 12, saturation 97, blood pressure 110/70, which is normal, and normal temperature. Exam normal, about increase the heart rate. Connected to cardiac monitor, and this is a cardiac monitor. How this differ from the previous patient? This is cardiac monitor showing narrow complex tachycardia with no clear B wave. So we are dealing with narrow complex tachycardia or SVT, supraventricular tachycardia. And this ECG was ordered again. This is narrow complex tachycardia and no clear B wave. If you concentrate, maybe you will see a retrograde B wave after the QRS complex here. So narrow complex tachycardia, given the hemodynamic stability of the patient, what do you do next? Patient is stable. Heart rate is 250. Patient in ER. Where's the picture of the patient? Not here. Try vagal maneuver, but don't delay adenosine. Some people, they will try vagal and they are not starting preparing for adenosine because this patient can turn unstable for any time. I mean, so some prepare for adenosine. If there is no IV line, try to put secure good IV line, and if you have central line, better to use the central line, the nearest to the heart. So somebody tried Valsalva and has been given 2 doses of adenosine, no effect. She now appears more ill and is complaining of chest discomfort. Now blood pressure is 80/60. Patient now becoming unstable. So in narrow complex tachycardia, abnormal rapid heart rate originated above the ventricle with narrow QRS complex. Is all SVT are narrow? No. Rarely SVT can present with wide complex tachycardia, and you have to differentiate. It will be very hard to differentiate it with VT. So SVT is many conditions, but I will concentrate about the most common, which is AV nodal re-entry tachycardia and AV re-entry tachycardia.
2 minutes, Dr. Kemal.
Okay. The two most common form of tachycardia, we have atrioventricular re-entry tachycardia and atrioventricular nodal, where the re-entry will be within the AV node itself, while in the AV re-entry tachycardia there will be accessory pathway. This is the accessory pathway, so the impulse will go from one side and come back from other side. So the classical examples, WBW, where you have accessory pathway, we know that WBW is 95 patients, they will present with orthodromic. Orthodromic means the circuit will start from the AV node. So it will give you narrow complex tachycardia. But 5% patients with WBW, they present with wide complex tachycardia, it's called antidromic. So the impulse will go from the accessory pathway and come back from the normal pathway. So in this patient, if you don't know this patient that he is WBW, first time you encounter this patient, I say treat as VT. And this patient is very stable, you can try adenosine. This is WBW with narrow complex tachycardia, and this is W after adenosine. See the delta wave, short PR interval, and wide QRS complex. And this is WBW with wide complex tachycardia, we say it's 5%. It resembles VT. Approach, patient stable or unstable, and this is the pulse. All of you familiar with the pulse protocol. We have to appreciate patient stable or non-stable. If he is stable, we can start Valsalva maneuver and adenosine first dose, then repeat adenosine with double dose. If not improving, go to medication after consult pediatric cardiology. If the patient is unstable, proceed with synchronized cardioversion. Cardioversion, some people, if you have a small baby or a small child and you have only adult bath, please don't cut the adult. Use the adult, but put one in the chest and one in the back. And this is the Valsalva. And you need to put the ice bag in that, but don't cover the nose and mouth. You can ask him to blow in the syringe, 10 cc syringe, or blow in. Or close the nose and mouth and blow. Sometimes for small infant you can trigger Valsalva by stimulating the air with the thermometer, but don't cause injury. Carotid and orbital massage is prohibited for children. Don't do it for children. Acute management, we mentioned adenosine, so red flag for all the cases I present, unexplained shock, cyanosis, tachyarrhythmia. Always check the pulses, oxygen, saturation, chest X-ray, ECG, and echo. And when in doubt, sort prostaglandin.